It's lovely to be here today at an in-person meeting, which I haven't been to many in the last year, as we all haven't. So today I'm going to be talking about a project that's been funded by the Inequalities priority area, and also, as Claire mentioned earlier, in the child health and maternity stream of the ARCs as well. And the project is essentially looking at how we can support services to deliver nice recommended mental health treatments to care experienced young people. And here we're looking at it under the umbrella of post-traumatic stress disorder, or PTSD. To provide some very, very brief background, so my team have worked with care experienced young people for many years now, looking at predictors of mental health and how we can improve support for mental health of this group in various different ways, because obviously mental health is a complex and layered phenomenon, and how we support it is also complex. But the kind of pointy end of it is our young people that access mental health services. We know children in care have incredibly high rates of mental health difficulties. At least half of them meet criteria for at least one psychiatric disorder, often multiple. And we know that their unaddressed mental health needs are a really core driver of a range of really terrible outcomes that can come to define this group in adulthood. They make up half of our young male prison population, a quarter of our homeless population. At 19, almost 40% will not be in training or education or employment. So outcomes that we'd really like to change, but have not really had much luck shifting for many decades now. So what we wanted to understand in this project is, if a young person in care or a care experienced young person makes it to mental health services, which is a bit of a challenge in itself, how can we ensure they're getting our best evidence support? So this trial is called the ADAPT trial, and in terms of where we're up to with it, so since July we've trained just over 20 services across England, and you can see the stars of where we've trained services, so a pretty good kind of spread of where they are. And that's across 11 NHS trusts. So the teams that we're training here are CAMS teams, core CAMS teams, targeted looked after children CAMS teams, and also social care-based mental health teams, which is where a lot of these young people go for support, or where a lot of the kind of front door to mental health services are. So they're the three different areas where we're training. The requirement is just that they're teams that work with care experienced young people in some capacity. We've trained over 200 mental health workers between July and October, actually largely thanks to the people on the screen here who are all experts in something called cognitive therapy for post-traumatic stress disorder, which is the type of trauma-focused CBT that we use here in the UK most commonly. Trauma-focused CBT is the best evidence treatment we have for PTSD, including for children that have experienced maltreatment or abuse and neglect. And then on this project, we're spending the next 12 months following up implementation, so understanding what these services need to use these treatments, essentially with the principle that just running a training is actually not enough for our services. So in terms of who we have trained on this project, I think really pleasingly the range of professionals really reflect the workforce. So we seem to be capturing who we know young people in care often go to for support. Clinical psychologists are just under a quarter of them, as well as social workers, and mental health nurses were our other largest proportion, but it's really dispersed. So a lot of art and drama therapists, psychoanalytic therapists, counsellors were trained. So again, it's whoever services want to put forward that are providing mental health interventions to care experienced young people. So these aren't people new to providing mental health interventions to that group, we're just training them in another kind of tool for their toolbox. In terms of feedback from the training, intentions are very high. So 90% at the end of the training thought that they would use the screening tool and that they would use trauma-focused CBT. So the screening tool is something called the CRISE-8. It's already a core measure in CAMS, but it's very rarely used, and incredibly rarely used actually with care experienced young people, even though we know rates of PTSD in that group are 12 times higher than in other groups of young people. So PTSD is very common in that group, but very rarely assessed and treated. At the training, we also collected information from our 200 professionals on what they saw as the biggest potential barriers to them using the screening tool and the intervention. And I think probably the take-home point from this is that the most commonly endorsed barriers were really around the young people. that they wouldn't engage, that the young people would have competing crises, which is often true: homelessness, placement breakdown, school refusals. That the young person might not be ready to engage in this kind of treatment, or that the treatment might re-traumatise the young person. What was surprisingly much less endorsed was things around the service and the professional. So certainly there were still concerns, but around a third of the sample endorsed them as the main barriers. So capacity within the service, their own confidence, supervision structures wasn't that commonly endorsed, and how the service was set up actually wasn't that commonly endorsed. And that's interesting because now, having started the implementation data collection, really the opposite is what we see, is that the service level structures are much bigger barriers to implementing than what's happening with the young people. Nope, sorry, I clicked the wrong button. So how are we collecting data on this project? I don't have implementation data to present to you today, but so you know what is going to happen on this project over the next year. Primarily, we collect data from the mental health professionals. They're our main participants. Every 3 months on a rolling basis after their training, they come to a focus group, and they also complete a questionnaire for us that helps us track implementation, but also helps us understand what the barriers are and think about how we can respond to them. There's also a huge amount of anonymised service data collection happening on this project to track how care experienced young people are coming into these systems, because it is absolutely the Wild West of decision making. So we're trying to somehow understand how those processes work. And then care experienced young people and their carer are automatically invited to participate in a kind of mini effectiveness trial if they're offered the treatment. We also have a wonderful advisory board of care experienced young people that are 15 to 25 years old and have guided every aspect of this project from very early on. And we have a professional advisory board as well that have also been really instrumental in guiding the study. Nope, sorry, I keep pressing the wrong button. So learning so far, what has worked well? Service sign-up has been incredibly positive, and that says a lot because Lord knows we all know there is no capacity in CAM services at the moment. So the fact that so many services signed up felt really positive, and I think really showed that there's an appetite for understanding how we can better address the needs of these young people. I don't think any of us think we're doing as good a job as we want to do. The training feedback's been really positive, and we've also, because of the very agile nature of this trial, been able to respond to many of the barriers already. So we provide additional webinars, supervision drop-ins to try to really promote confidence building around using the intervention. And almost all teams have started using the PTSD screening tool, which is brilliant because we only finished the trainings in October. Almost all of them, at least in some capacity, are using it. And we're now seeing some services start to use the intervention. And we're really starting to see now a bit of a divide in some services really taking it on board, some services being really hesitant, which I guess in a research sense is useful for us. In terms of the challenges, these are the kind of 4 levels that we look at implementation barriers on our project. And I'm going to go from right to left. By far, the biggest barrier to implementation in a research sense on this project have been the trust level ethics approval processes, which are completely not fit for purpose for really busy services. I don't know if anyone here manages them, but they really need to be overhauled. At the service level, the electronic clinical notes systems are an absolute disaster. And the fact that almost every CAMS uses a different system to record notes, I shouldn't laugh about it, but it's one of those if you don't laugh, you'll cry kind of situations. The service systems for collecting anonymised data is terrible, but we've had some real implementation success. So when we first started working with services, most of them we realised quite early on weren't even recording if a child was looked after by a local authority. So they couldn't tell me if they had any children in the care of a local authority in their service, which for a group of young people that rarely have consistent advocates is really problematic. And a lot of services have been able to update their systems now. The capacity to address needs is obviously an issue. Leadership, endorsement, supervision structures, they're all issues that are coming up. Something perhaps quite unique for care experienced young people is how services see themselves and whether that service actually ends up seeing themselves as a mental health service, particularly for these services that sit between social care and CAMS. it's hard for them to work out sometimes. At the clinician level, certainly beliefs around diagnostic frameworks and beliefs around CBT treatments and confidence. Young person level, we're too early in the project to understand. I'm just going to finish on this for 30 seconds as a good news story that's coming out, being launched on the 6th of December. Part of this project, we've co-developed a series of resources around PTSD and trauma-focused CBT, co-developed with young people for young people, as well as a bunch of training videos for therapists. They're all going to be freely available and launched 6th of December on the UK Trauma Council website. These are the lovely people I work with. Thank you.